Welcome, Dr. Senthil, to the DIL podcast. DIL is Digital Health Innovations for Long Life. It's an absolute pleasure to have you on this podcast for several reasons. One, very few doctors kind of get into digital health, but you have actually done so at least maybe a decade or more before a lot of people who are doing it now or even still imagining of doing it now, and that makes you one of the pioneers of digital health. In fact, digital health was probably going by the name health informatics at that point in time. So welcome to our podcast. Another reason obviously is the fact that you are also a college mate. We went to Stanley Medical College together. That's something I guess nobody can actually forget at any point in time. So wonderful to have you around. The broad structure of our conversation is probably looking at three things. One is tracing the career pathway on how you got interested in digital health, and then as years went by, how did you build your expertise through your career, and also the projects that you are associated with. And as a consequence, we'll also talk about the present of digital health, the past, and also the future of digital health, on where it is actually going to go, the trajectory, how it will be beneficial to people, patients, the health systems. And the purpose of this conversation is also the fact that at Mallareddy Vishwavidyapith, we have started India's first school of digital health. And talking to experts like you, we are kind of trying to know what is the best focus areas to teach in digital health, especially for the curriculum, because the future students has to take it up and then take it up even further, and it's best we teach them what is currently required, not something that is written maybe a decade ago in the textbook. So those are some of the areas that we will cover in this podcast. Welcome to the podcast again. To start off with, I think if we can start all the way in the beginning on when and where you are born, and then your first interest in digital health, I think that would be a great start. Welcome, Dr. Sindel.
Yeah, thanks for having me on, Dr. Suresh. It's always a pleasure to see you. I had a chance to see you after nearly 20 years in person since our medical school days, and again, I'm talking to you today. So I'm super excited about this. So let me start with how I got into this field way back when. So in the 90s, when I was a high school student, I got into computer programming like a lot of high school students do. And as somebody born in the 70s, grew up in the 90s, uh, the computers that we had back then were very very low powered. So we had to make do with 640 kilobytes of RAM, like Bill Gates famously said, it's ought to be enough for everybody. And so I started out programming with an MS-DOS computer on an 8088 processor, and slowly that transitioned into writing applications for the hospital during our medical training days in the 90s. So
Do
it,
you still remember your first computer?
yes, it was my school's computer. It wasn't my own. The first computer I used was in the computer lab of my high school, and it was an 8088 with a monochrome screen, without a graphics card, with a 640K of RAM, without a hot disk. So we had to make do with all those minimal resources, doing all kinds of shortcuts.
Yeah, you are still on floppy disk, those 5.5 inch ones, or the smaller, slightly
Oh yeah,
smaller?
yeah, it's the one with a 500 quarter disk. I think it's like 360 kilobytes capacity, if I remember correctly,
And
with a
mouse was
500
there, or
quarter.
you have to navigate yourself with the cursor?
No mouse, no graphical interface.
Yeah, yeah.
Yeah.
Okay. So, what were the application program that you said that you are actually developing when you are in college?
So I did couple of things. There is a private hospital in my hometown,
Mhm.
and during my summer break between high school and a medical school, the doctor who owned that hospital asked me if I can help write some applications for his hospital because he knew that I knew programming, and medicine is also something I was going to do, and something that I'm interested in. So I created a patient record system in FoxBase back then. Uh, so that was my first application for healthcare.
1990s, I believe.
Yeah, late 90s, yes.
Mhm. Anything else you did during your student days?
Yeah, during the medical school, it's funny, knowing a little bit of computers actually helped me make a little bit of money. So, as a student living in the dorms on a limited budget, it's always helpful to get some extra cash in hand. So I used to assemble and sell computers, and my customers were doctors in the hospital. So I got to know a bunch of doctors who were into computers back then.
Well, I think that was the time where assembling computers was a very sought after skill because
Yeah,
the
yeah, it was.
alternate ones, I believe, was Hewlett Packard and Compaq, which are probably selling at a huge premium at that point in time. Whereas if you are able to assemble computers, I think it would cost like half the price or maybe even cheaper also.
I would think so, about half the price.
Mhm.
So I would go with them to Ritchie Street and
Absolutely.
talk to both the parts vendors as well as the people for whom I was assembling the computers, figured out what they wanted, and then get the right parts for the right budget. So those were fun times.
Okay. When did you last visit Ritchie Street again?
Oh, I went to Ritchie Street, I want to say about 10, 15 years ago.
Hmm.
And so this was about 10 years after I moved from Chennai to the US. And when I went back, a lot of things had changed because the branded computers have become affordable these days. And also, a lot of people prefer laptops. So the assembling and selling computers business had just vanished. So it was interesting to go see the changes in Ritchie Street.
Well, a couple of memories that I have during our college days is one of my school friends worked at Reddington, which was one of the, I think, dealers for Hewlett Packard and Compaq. So, whenever I went to meet him, you used to see all these big boxes of computers coming from the nearby, what you call, airport. And those are things I kept dreaming one day I'd actually buy them. And the second thing is obviously Ritchie Street is part of a long walk that I used to take from the British Council Library, crossing the Spencers and then the Poompuhar and then Ritchie Street and then walk all the way to Hindu bus stop and then take a bus and then go home. So I think those are memories still etched in my head during the college days. We also try to do not something similar as in assembling, but we try to kind of find people or sell computers to people directly and then bypassing the dealers and provide them some relief on the cost. So I think we try to do all sort of things to kind of keep us engaged. Um, how did you kind of proceed after the medical education?
So there were a few events that catalyzed my entry into medical informatics. So during medical training, I helped a couple of departments in our hospital digitize their medical records as well as their images. And then there was one time when during our internship, I accompanied one of my patients to the medical records room because the patient's father had gotten discharged a few months ago. And so the patient's son came to the hospital to get a copy of his father's records. So I took him to the medical records room, and that's my first trip to the medical records room. And I saw paper records from about probably 50 years ago were stacked ceiling high in that room.
Wow.
And so that was an eye-opening moment. I thought, okay, there's got to be a lot of knowledge in those reams and reams of papers that have faded. The ink had faded, but there's so much knowledge in that. If we could mine all that knowledge, we can discover a lot of new medical knowledge to improve the practice of medicine, to discover new medical knowledge. And so around that time, I was trying to figure out what I want to do after my medical training. And
Which
then I
facility?
realized there's this field called informatics, so I got into that.
Yeah, which facility was this, if I can interrupt? When you
Uh,
said like there was like 50 years of records.
yes, yes, it is in the Stanley Hospital, Government Stanley Hospital in Chennai.
Mhm.
And this medical records room is probably about a 500 square foot room right next to the dean's office.
Okay.
So one visit to the room kind of, just flipped a light bulb in my mind.
Okay. So this was when you are almost completing your medical education, I'm assuming.
That is correct. Yeah, it was during our internship.
Okay. And then how did you start thinking about medical records and digitization?
So, after that event, I was trying to decide what I wanted to do after my medical training. So, I was interested in research more than practicing. And I was interested in genetics, and also I was interested in computers. So, searching on the internet, I found that there is this field called informatics, which is a formal, methodical, and structured way to do what I was doing in the hospital in a haphazard way on my own. So I figured, okay, I should learn this in the proper way. And so I applied for PhD programs at multiple universities. And then Utah turned out to be a great place where they had a strong theoretical foundation as well as they had practical hands-on implementations. And that's something I liked. I'm always being hands-on, uh, always try to implement things rather than only do theoretical things. So Utah gave a nice mix of the two. So I just packed my bags and came to Utah.
And I believe this was in the early 2000s.
Yeah, that's correct. Yeah, it was in the early 2000s, and I'm still in Utah. 25 years.
Well, I think that's great to hear. I mean, I think that's one of the things that happen. Sometimes we go to colleges and probably stay around for a very long time.
Yeah, yeah.
Do you still remember the kind of theory coursework that you had in Utah? Any kind of projects that you took during your PhD time?
Yeah. I can tell a little bit about it. So the back then the program had a few required courses, which is the first one is the Introduction to Medical Informatics course, and that followed that the short-lived and Semino's medical informatics textbook. It's that blue textbook that a lot of medical informatics graduate students would have read, and it closely followed it, and it also had a lot of uh, first-hand experiences from the University of Utah as well as Intermountain Healthcare, both of which are pioneering medical informatics institutes. So that was that, and then the next one that I found to be super helpful is the medical terminologies and standards class. In fact, at first I thought, what kind of class is medical terminologies? I mean, for somebody with a medical background, should I learn medical terminology? So I was kind of nonchalant about it. And then once I took that class, I realized this is not the terminology that we learn when we learn medicine and surgery and anatomy and physiology, but this is actually how do we structure medical information so that a computer can process it intelligently. And that course was the foundation for everything I did afterwards. So my PhD research was in machine learning and artificial intelligence using the state-of-the-art methods from the early 2000s. However, that was really built on the foundation that was provided by the terminologies and standards class. So because of that, my career has covered two main areas. One is artificial intelligence and machine learning, and the other is data standardization and interoperability. So I've followed and pursued these two areas side by side. So Utah gave me a really good foundation to do that.
I think these are some basics that we still need to teach our students, especially the terminologies and the standards. But uh, as you rightly said, these are not something that is actually taught during regular practice or regular medical curriculum, but more from the perspective of digital health, especially from the perspective of interoperability between information going from one to another, so that people don't mistake what is what. Not necessarily from the kind of case sheet writing point of view, but more of a machine understanding point of view. And also the terms that you kind of mentioned about machine learning and artificial intelligence are become fairly common now, but I think during the early 2000s they were all again fairly more prevalent in the labs and the universities rather than in the actual normal life. uh, what was your project during the PhD time?
My PhD project was creating an end-to-end framework, starting with data preparation uh, to creating machine learning models to predict a patient's outcome, as well as recommending interventions to improve the patient's outcome. So, in technical terms, I call that temporal reasoning in medicine.
Yeah.
And the method that I used for that is dynamic Bayesian networks. And you can think of it as a time series model that uses probabilistic methods under the surface. So it's like a hybrid of hidden Markov models and Bayesian networks. If I can relate that to other foundational methods. So it's essentially time series modeling and predicting the future, as well as recommending interventions to change the future, improve the future, using probabilistic methods.
Um, well, that sounds so relevant now. But when you kind of proposed this in the early 2000, how was the receptivity to this idea? And your kind of project also requires, I'm assuming, lifelong data collection, or rather, because you need to incrementally keep adding data so that you also get incrementally generated interventions that are hopefully lifelong. How was the receptivity to this idea then?
So I was lucky that I found an advisor who was already doing some early research in this area. My PhD advisor's name is Professor Peter Haug, who recently retired. And he's a physician and an informaticist as well. And he has worked on probabilistic machine learning for a while. And I added the time series component to it. He had started working on it, and then I was one of his first students who actually built it out fully. So having the background in terminology, data modeling, data standardization helped me a lot. So what I did was I took the data from the Intermountain Healthcare's electronic health record, which was a homegrown electronic health record system that was created at Intermountain Healthcare in Salt Lake City. So I got access to that data, and then I structured the data in a way that is useful for time series, machine learning, and prediction. However, there were a lot of roadblocks. We did not have a powerful enough computer to do the work, and so I essentially ended up buying my own computer. As a PhD student, that was a big investment. So I built my own machine, and essentially, took it to the hospital, got it through their security approval, have it there for the research, and then I also had to find the right algorithm to do this machine learning work. And back then, there wasn't a library that I could use. Turns out the library that I ended up using for my PhD was published by somebody 2 years after I started my PhD program. So the technology was very nascent at the time, but eventually, things worked out, and I was able to do this end-to-end framework, and then successfully proved these methods as well as their generalizability in two clinical conditions. One is early detection of sepsis, and the other is insulin dosing in the intensive care.
Well, great work. I think we'll come back to this concept when we talk about digital health and the future, because I think it's absolutely relevant, maybe even more today. And some of the challenges that you mentioned about lack of computing is probably addressed. Um, I think you also put your Richie Street skills to best use in assembling your computer in and kind of installing it in the Utah Medical College. So, what happens after PhD?
So after PhD, I had the opportunity to work in both industry as well as in academia, and I ended up working full time in the industry and then as a product lead at 3M Healthcare. And simultaneously, I started working as a part time researcher at the University of Utah in a different department in epidemiology. And so I ended up doing this parallel full time in the industry and part time in academia for nearly 15 years. So in the industry, I took uh, positions of increasing responsibilities, and so I became responsible for a large multi-million dollar products research and design at 3M. And subsequently, I went to a large startup that was co-founded by multiple health systems, where I led the product design, the product side for data standardization, both the structure as well as the content of the data. And in fact, a few minutes ago, you correctly pointed out that we are not just trying to write stuff on the computer. If all we are going to do is write pages and pages as text, we are treating the computer as an expensive replacement for paper. And I think that's just a waste of everybody's time and money. So, what we really need to do is to make these computers process the patient's information both at the individual level and at the population level intelligently, and then learn and infer things out of it. So I got to do all those hands-on implementations in the industry. At the same time, in my part-time academia role, I I got to work on uh, some cutting-edge research, which I could not do in the industry because at the industry you don't have large-scale access to patient data. And also at the industry, you always work on shorter timelines where you want to turn things into a product that you can release. But on the university side, you can do a lot more experimentation and learn a lot more. I also had access to data from two large healthcare systems. So that worked out really well for me to learn various aspects of digital health. And then after a few roles with increasing responsibilities, I led a startup that was incubated at the University of Chicago called Nightingale Open Science. And so that's where I got into artificial intelligence and machine learning with multimodal data. So I worked on medical images, waveforms like electrocardiograms, videos like echoes, as well as biopsy images, radiology images, as well as structured data. So I got to work on multimodal machine learning as well as data standardization. And after that, I pivoted back to a full-time role at the University of Utah, where I work as a faculty member now.
Well, I think you have been living a dual life in the industry and also in the academia. I think that's again one more rarity, and both has its advantages and probably challenges, not disadvantages actually. Is it possible to at least briefly talk about the products that you are associated in development at 3M?
Yes, yeah. At 3M, I joined as a medical informaticist in the healthcare data dictionary group. And so what that group does is we they had been building a terminology server that takes various standard terminologies like SNOMED, LOINC, Orexnom, various flavors of ICDs, as well as various local terminologies that are from the vendors who create electronic medical records or lab systems, pharmacy systems, and so on, as well as the end users who want to add their own terms to the terminology. This healthcare data dictionary took all of them and integrated them together so that data over several years or even decades can be interpreted meaningfully as these terminologies change. New versions get released every 6 months or every year. Uh, all the old data and the new data can interoperate. So that was the goal of the healthcare data dictionary, not to mention data from different hospitals, labs, pharmacies, and so on. And when I went there, I became the research lead for that product, and I added new capabilities to it. So, how do we concurrently support multiple versions of various local and standard terminologies? And then I ended up co-authoring an HL7 standard called Common Terminology Services, the second version of it. I co-authored the functional model, and I was closely involved in HL7 standards development as well as SNOMED. I was one of the SNOMED committee members representing the United States, and so did a lot of standards development work, and eventually I ended up working on natural language processing at 3M. So this is the previous generation of natural processing before machine learning. So we would use rule-based and statistical machine learning. So I did a lot of work in that area, and eventually I started leading a group that would build a data platform for various product development at 3M.
Oh, well, great to know about your work at 3M, but can you briefly explain or expand on the SNOMED also for the benefit of our viewers?
Yes. It's great that you asked this question. So SNOMED, its root, its roots go back, I want to say 30, 40 years, but I'll just talk about the current version of SNOMED or the current generation of SNOMED. So it has become the world's uh, biggest clinical terminology. It covers just about any domain of medicine. I can think of diseases, signs, symptoms, procedures, medications, microorganisms, body parts like anatomy, uh, and and then all the supporting codes required to mention somebody's history and so on and so forth. So it has about 500,000 concepts, which is an order of magnitude bigger than any other terminology. For comparison, the another big terminology, ICD-10, has about 40,000 concepts or 40,000 terms. Really, it's not quite concept based. And SNOMED is so extensive. And not only that, SNOMED is designed to be machine interpretable. And I cannot say any other terminologies with such widespread adoption that has machine interpretability as part of its core design. And SNOMED is very special that way. But not only that, SNOMED also has a way for each country or each organization to extend it. So they have a federated model where there is an international edition that includes the various diagnoses, procedures, medications, microorganisms, and whatnot that the whole world would be interested in. They have around 50 countries as members. They create their own national extensions. US has one, India has one, there are another 40 or so countries have their own extensions. But not only that, each organization or hospital, if they want to add their own codes to it, they can also get an extension and do it in a very consistent way, in a machine interpretable way. So if somebody wants a really good terminology to build their own application, SNOMED is where they should start looking.
Well, great. You also mentioned about ICD-10 in this conversation. So, how is SNOMED and ICD-10 related, and is there any kind of a overlap, or can we understand that SNOMED is more of process documentation in a structured way, whereas ICD-10 is more of very specific disease codes? How are they both related?
So ICD-10 is probably the first terminology ever, I want to say. I think it started around the time of Florence Nightingale. Uh, how long ago was it? Like 100, years ago, uh, where Florence Nightingale uh, created a list of terms to tabulate the various diagnoses. I think it goes back to that time. And it was created during the days of, paper and pencil, right? So there were no computers back then. So they wanted a simplified way that people could classify things, classify diseases into like whether something is a cardiovascular disease, pulmonary disease, infectious disease, and so on. And they did not think of various things that can happen when we bring computers into the mix where we can process data at a much bigger scale. SNOMED has evolved. We are now in the 11th edition of SNOMED. Some countries like the US are still in the 10th edition of SNOMED. And the 11th edition of SNOMED has some good properties compared to the 10th edition, uh, which is what computer scientists call as ontology, essentially a formal model to make it machine readable. However, ICD still tries to classify things, whereas SNOMED tries to define things in an unambiguous way. So the way ICD works is everything is a tree structure. So we just start at the root level and we keep on splitting things. So every concept or every term in ICD has only one parent. It can only belong to one category. However, if you think of some disease like bacterial pneumonia, it's both a pulmonary disease as well as an infectious disease. It belongs into both categories. So if you want to find all patients who had pulmonary diseases, you may find pneumonia if pneumonia is defined as a pulmonary disease. But if you're trying to find all patients with infectious diseases, you may not find that patient. So ICD is really good for classifying things for statistical purposes, for epidemiological purposes, or for billing purposes. It's not well suited for clinical use at the bedside. And SNOMED is designed with clinical use in mind. So something can be an infectious disease, a pulmonary disease, a cardiovascular disease at the same time. Uh, and we can also say a bacteria is not a virus. So if you only want to find bacterial diseases, you can easily exclude viral diseases. So it has a lot of computability built into the design, which ICD doesn't.
And SNOMED has a lot more granularity compared to a very structured way of ICD, and I believe both of them are now in their 11th versions.
Yeah, that is true. Yeah, SNOMED CT, they just start, they keep incrementing the version by the year. And so one thing that you mentioned, the granular area of SNOMED, it's it's extremely powerful, but at the same time, it scares beginners, and because it's so extensive and the model is complex. And if you look at the number of tables in SNOMED, if you download the default installation, you probably have like a dozen tables, whereas ICD has one table. So it discourages people, but I would say it's worth the learning curve, worth putting the effort into the learning curve because it's super powerful. But at the same time, I've heard doctors say that ICD is easy for them to understand and SNOMED is complex, and I completely agree. But ICD is not designed for doctors to see. If the creator of a digital health application shows SNOMED codes to the doctor, then the application developer has failed. They should make their application smart enough to leverage everything that SNOMED provides them, but still make the application user friendly so that they don't scare the users away by showing the complexities of SNOMED. For example, a pharmacist doesn't try to make somebody remember the pharmacodynamics and pharmacokinetics when somebody's prescribing a medicine. So it's the job of the application developer to hide all the complexity and make it user friendly.
Well, great. I think we'll come back to the challenges of electronic health records because there are a lot of them. But I think going next to the startup that you are associated with, the Nightingale Foundation that you mentioned. So, what was the activities that you are associated with, and can you describe about the startup itself?
Yes, so Nightingale Open Science was co-founded by two professors. One is a physician from University of California, Berkeley, Dr. Ziad Obermeyer, and then there's another professor of uh, uh, computational economics. His name is Senthil Mulainathan, and he's at MIT now, formerly at the University of Chicago. So they brought me on board to lead Nightingale Open Science, which they had started about a year before I joined. And Nightingale's mission was making large de-identified healthcare data sets available for knowledge discovery. So they both have strong expertise in machine learning, and they realized that the medical records that are written by clinicians are biased by their mental model of a disease or a treatment because their knowledge is based on their medical training. And so, if we use only what the doctor wrote in the patient's medical record, it's hard to discover new medical knowledge. We will only rediscover current medical knowledge that's in the textbook because that's what the doctor has in their mind when they treat a patient. So, what they wanted to do was to take the most raw data elements which are not colored by current medical knowledge. So, they wanted to start with imaging, waveforms, videos, and when I say imaging, both radiology as well as pathology, take all of these and take patients' demographics and the outcomes, and then use machine learning methods to discover new medical knowledge. And there were several success stories, and so I was brought on board to make sure that the data that we collect are meaningful and useful. Given my expertise in both data standardization and interoperability, as well as machine learning, I uh, created requirements for various data sets that Nightingale was acquiring, along with how do you validate that these data are good and are of high quality, and then how do you make sure that these data are de-identified before we can release them. So that was one thing I was leading, and the other thing I was leading, as it's a startup funded by grants, so I was involved in a lot of fundraising. So I ended up leading uh, many grants, obtain new grants to run the organization, as well as build partnerships with multiple universities who wanted to use our data for machine learning research, as well as teaching. So we got data from multiple countries, from multiple hospitals in the US. We got data from India. We got data from a company that was based in Taiwan. So we were able to publish a lot of data sets.
Okay, great. You also mentioned about India just now. So I'm assuming you are also associated with some of the projects in India during your time at 3M and also at Nightingale Open Science. So, and COVID also came, something that we cannot actually forget. And again, you are associated with some of the projects and services during the COVID time. Can you mention some of them?
Yes, my earliest interaction with our colleagues in India was through the Indian Association for Medical Informatics. So I joined that organization, I want to say about 15 years ago, probably 15 years or probably 20 years ago. I joined as a member and I eventually became their international representative, and also I became an executive committee member. So I was involved in giving recommendations to like writing white papers that the organization submitted to the government around unique health identifier for the country, as well as uh, the curriculum development group that was part of Indian Association for Medical Informatics. So we worked on an earlier version of the medical informatics curriculum for for education in India. So since then, I got talking and closely interacting with a lot of colleagues in India, and that association still continues. I continue to advise students, and in fact, when COVID hit, one of the medical students who was a member of AAMI and we co-led a COVID quarantine management system, uh, what we call as a privacy protecting COVID quarantine management platform. We called it Covenant. Essentially, we made up a backronym from COVID, and we got a team of volunteer developers, volunteer security experts who would validate the security of the platform, as well as translators from all over the world who translated this application into 20 different human languages. So you could have a cell phone app or a web app in 20 different human languages. This was a completely volunteer-led effort, and all of that came through COVID. During the COVID time, through the Indian Association for Medical Informatics and my participation there.
Wow. Well, great work. So now you are back in University of Utah, I believe.
Yeah.
What is your role in the present version of your joining the University of Utah?
So after working in the industry at 3M as well as a large startup called Trueta and subsequently Nightingale Open Science, I realized that the both the computational power as well as the AI algorithms have made tremendous progress in the last 10 years. And we can mainly attribute that to the computational power and the GPU compute libraries that NVIDIA has created, as well as the machine learning algorithms like the backpropagation algorithm, convolutional neural nets, and so on, that various computer science pioneers have created. That has changed the way machine learning has been done in medicine. So I realized that to solve some big problems using these capabilities, I need to be at a large university with a well established informatics infrastructure. And since I was already a part time researcher at the University of Utah, and they also had the opportunity for me to join as a faculty member, I took on that opportunity. So, so I went on from being the chief medical officer and the product lead of Nightingale to an assistant professor at the University of Utah. Uh, so essentially, I'm starting from scratch in academia as a faculty member, but at the same time, I got access to the informatics infrastructure, the data resources, the high performance computing resources that the university has, as well as the other highly accomplished faculty that I can collaborate with who have expertise in different areas, plus all the industry experience in creating scalable, implementable products and the industry connections. So I'm putting all of these together on working on solving what I think are some big problems in healthcare that are worth solving.
Well, I'm sure the University of Utah is absolutely lucky to have you with all the experience. You mentioned about some of the projects that you are actually working on. So, what are you currently working on?
First of all, I'm lucky that they took me on. So I thank my current department that had faith in me. So what I'm currently working on is to integrate the information from free text notes with structured data in the electronic medical records. Because as we know, some data in the medical record, like the vital signs, the list of diagnoses or problems, medications, labs, and like history and allergies, these are all in a structured format. But a lot of medical information is in free text notes. And there have been a lot of effort to use various natural language processing algorithms, including ones that I've used in the industry. So they used to be rule based or statistical, and they were very narrowly focused. So people would create an NLP pipeline to infer somebody's smoking status or cardiac ejection fraction or the presence of the mention of pneumonia in radiology reports, for example. So they were very narrowly focused. So the current machine learning capabilities give us an opportunity to make it generalizable, to do it at scale, to extract as much clinical information as possible from the free text notes. So that is the part that I'm working on. So currently I'm working on making the extraction of almost all the information that are present in free text notes possible using the modern machine learning approaches, as well as doing it in an interoperable format with the structured data that's already in the medical record. So this is where my background in interoperability comes in.
Um, some people broadly assume that the present day AI focus and machine learning all started with the smartphone cameras, and then you have all these images flooding the internet, and then you actually needed algorithms to kind of make sense of all the data that is actually coming. But when it comes to healthcare, there are two different worlds. One, a world where there was already documentation actually happening, imaging already happening, tons and tons of images being generated, and also a lot of data that is actually being generated, where the challenge is more of structuring and then making them understandable by the machines and hopefully making sense of them. On the other side of the world, especially in India, uh, there's a lot of healthcare service that is being delivered or is happening, but there's very little documentation that is actually happening, especially with the services. It's not all lack of documentation, but there's also partly data that is actually being generated, especially on the imaging side. The radiology is still thankfully digitized. We are not documenting or storing them, but at least the process of radiology or taking images has been digitized. So there are uh, huge variations on the similar service that is being delivered across different countries, different areas, even within the country. Now, the broad idea is digitalization or digital health is going to go forward, and hopefully at some point in time these uneven structures would hopefully be corrected. But in your opinion, and with your long experience in digital health, health informatics, data standardization, and also going through the process where you know how much of it is a challenge, how do you imagine or visualize digital health in the next 10 or 20 years?
So, digital health, even in places where there has been strong institutional as well as government support, places like US, Canada, Australia, several European countries, the ones that I'm familiar with are UK, Netherlands, and a few others. Even in those countries, it's been a challenge. It's so hard to keep up with emerging technology. Things are changing every year, but if you look at airline cockpits, for example, they haven't changed in decades because in a very safety critical area like healthcare, constant change is hard. So we have to do it in a very judicious way. And also, there has been a lot of trial and error. If we look at the standards themselves, when I started my informatics training, there was HL 7 version 2, and version 3 was just starting. And it did not get widespread adoption because it was too complex. But then that led to FHIR, Fast Healthcare Interoperability Resources. And FHIR has gotten widespread adoption because it's both simple and it has the richness of the version 3 of FHIR. So simplicity of version 2 and the richness of version 3, and it's a lot easier to implement. So, having done my medical training in India, and then having done my informatics training in the US, I've seen two very different healthcare systems, though both are based on the same school of scientific medicine. The healthcare delivery systems are vastly different. So here, a busy day is when a doctor sees 25 patients. In India, if a doctor sees 25 patients, they'll be in heaven, right? Nobody sees less than 50 patients a day. Often they see more than 100 patients a day. I've seen more than 100 patients in an outpatient ward back in my medical practice days in India. So there are unique challenges in the Indian ecosystem. However, there is also a lot of opportunity to use current technology by leapfrogging a lot of technologies that would not scale in an environment like that. So perhaps the current machine learning used judicially, always keeping patient safety at the front of our minds, I think help us overcome some of those scalability difficulties in a high volume environment where doctors don't have the luxury of sitting in front of the computer and typing.
I think I completely agree with you. In fact, when I used to practice almost every day, I used to see around 200 patients, and I still am not sure if there is actually an electronic health record which can in any kind of a meaningful way document the interaction with 200 patients in one day. So I think, as you rightly said, the present generation of technologies may not actually be sufficient to probably kind of address the requirements, and we definitely need a whole new set of technologies to uh, maybe be used in these kind of areas, and that would also provide us the opportunity to leapfrog and maybe go to the next generation. But if you kind of let's say imagine in a very futuristic way, how do you imagine digital health, especially from the perspective of a patient or a normal person? 10 years down the line, what will digital health mean to a normal person?
So I think one thing we can do for sure is making the entire medical record of a person's life accessible to all the healthcare providers, no matter where they are, as well as the patient and their family and caregivers. Because right now the medical documentation is incomplete and also it's fragmented among multiple places, multiple doctors, multiple hospitals, labs, pharmacies, and so on. And then the patient carries around small snippets of that information. I think that can be overcome. There are some more things that hopefully, if the current AI, the machine learning approaches become more reliable, then we could build assistants for a patient that can explain to the patient what's happening with them, what is the likely prognosis, as well as what are the treatment options that are available, because it's most patients do not understand it. Not all of them have a family member who is highly knowledgeable about healthcare. So if technology becomes safe and reliable enough, that is doable. At the same time, there is also a lot that we can do, especially in the Indian context. India has a billion people, billion point four, and they are underrepresented in clinical studies. So all the textbooks we use, all the medical journal articles we read, they are not based on the Indian population. They do not take into account the genetic variants in Indian populations. Also, the various subpopulations, since India is a highly endogamous country, the subpopulations are highly endogamous. And so, if the medical records are available for research, we can discover a lot of new medical knowledge, both based on genetic factors as well as environmental factors that are unique to the Indian population. And we can make precision medicine a reality in India with a billion point four people. So even if the current AI doesn't become any more reliable or safe, that doesn't matter. We currently have enough technology to take all the medical images, all the medical records that are available, and discover so much knowledge that can be used at the bedside.
Well, great. You actually mentioned several things here. I'll try to put them into two buckets. One is sourcing information from as many people as possible, given that we actually have 1.4 billion people. And the second basket is conveying them information, or rather non-clinical interventions, or rather the context or the content in a way that they can actually understand, which is not being done as well as we would actually want them to be. So I think the second part, I think we have substantial AI agents which can potentially do the role, because as long as the interventions are documented or reasonably structured, I think we can maybe translate them and convey it back to the person. How much do you think language is a challenge in sourcing information? Because electronic health records, at least in my opinion, are done in English, and obviously the terminologies are all in English. Practice happens in local language, and India is the only country in the world with 22 official languages. So, if you would want to kind of even imagine reaching 1.4 billion people, uh, then would this still would the platform still apply, or do we need to make substantial modifications to it?
So That is an excellent point where technology can help, and this is one place where without technology, I don't see another solution. We cannot have somebody translating all the medical records into every language that the patient speaks. So, uh, machine translation has been becoming more and more powerful every year. Back in the day when I used to travel, it was so hard to travel to a country where I don't speak their language and they don't speak English. These days, I don't find any problems. I learn a few phrases to greet them, but beyond that, I just use the translation app on my phone, and so they are becoming really good. However, there is one caveat that affects both these translation applications as well as these AI agents, which is how safe and reliable are they? That is something that needs to be validated because even when it comes to these AI chatbots, a patient could ask questions about their health and it would answer. But we've seen so many problems with hallucinations, what clinicians would call as confabulations, that these large language models do. But not only that, they also have this tendency to be sycophants, which people have actually defined in literature, that these LLMs always try to please you rather than disagree with you. And they even give harmful content to please somebody. So there have been a few suicides where people who are talking to chatbots ended up committing suicides. So we need to, do some more work on the safety and reliability for all these technologies, and I think it applies to translation so that they can be used at the bedside.
I think that would be a very critical challenge because obviously most of us can speak only a few languages, not all the languages, and not knowing any language to using digital assistants to kind of communicate is perhaps the first step. But then there is also a significant difference between normal language for local use or maybe essential use versus medical language, and then medical language versus high quality medical language which can be good enough for treatment, I think would again be a huge significant step. So there are several steps here, and as you rightly said, I think it can only be solved with technology, but technology comes with several challenges also along with language itself, which is a serious challenge. You actually mentioned about the capability of raw data and the fact that we understand what we actually know. And collecting raw data also is dependent on the current generation of sensors. And what I'm thinking is maybe we'll get a whole new bunch of sensors which will be helping us to document more and more. Probably something like, let's say, hyperspectral imaging. We are presently relying on a very narrow band of wavelengths for imaging, but if we can expand the wavelength itself and if we start sourcing more and more data, we would actually be probably getting more data to interpret and more data to understand about our own living ecosystem and the diseases. But also, as you rightly said, if more machine learning or more natural language processing addresses where within the ambient environment that we are actually talking, if the content is actually picked up, parsed, and then structured in a meaningful way, and then we could possibly understand. I think a combination of so-called ambient intelligence and the next generation of sensors could potentially help us to leapfrog and understand more about us in a better way. So this is where I'm thinking we'll probably go in the next 10 or even 20 years. And hopefully digital health will help us to live our day-to-day life or maybe even help us to lead a very long life. And there's a lot of discussion currently happening in the area of longevity also, on how we can actually extend our life. How much do you think this can benefit the entire population versus a small segment of people who can actually benefit from these areas?
So there are things that can help large segments of the population. So you mentioned about hyperspectral imaging. Today it sounds like science fiction. However, 100 years ago, X-rays would have sounded like science fiction. And, I don't know, like 50, 75 years ago, MRI would have sounded like science fiction. So we should see if it provides us valuable new knowledge. And the only way to do is by trying it out. So, uh, new ways of data collection, new sensors, these are all things that should be investigated. We don't know which ones will be beneficial and which ones will not be, but how else can we find out unless we try it, right? So that is one, and the other is also uh, focusing on public health and population health to see where is the biggest return on investment. So, uh, for example, if somebody doesn't have a balanced diet and they are eating too much simple carbohydrates and not enough vegetables or protein, those are low cost interventions that can help with cardiovascular diabetes, like metabolic uh, diseases. So I think we should do both. It can't be just one or the other. It cannot be just the cutting edge technology that only a few will start to benefit tomorrow versus large population interventions that can benefit hundreds of millions of people. I think both ought to be investigated, but of course, the amount of investment they take will be different. Maybe a handful of researchers work on each cutting edge idea. However, there is a large investment into population health. So I guess that's where the question of economics comes in, where how much do you invest in hyperspectral imaging versus proper nutrition? So I guess these are questions that policymakers have to contend with.
I think there's also one more area policymakers should potentially consider is, as you rightly said, these are all different areas. One is in public health, the other is in cutting edge research. Uh, and also, you mentioned the fact that potentially, if you are able to source data from 1.4 billion people, or maybe 7 billion or 8 billion people in the world, uh, we could potentially also help them on reducing the disease incidence, managing the existing diseases if they have, and also giving them advice on how to lead a better life. Uh, don't you think there should be some kind of a guidance note on the minimum data points that need to be collected, and some kind of a operational requirements on how these data points can actually be collected, and some kind of benchmarks to say that, if we can collect these minimum data points at this point in time with these kind of resources, as you mentioned, we can actually provide them with some kind of basic interventions, probably to each and everyone. So some kind of minimum data standards to be collected, some kind of minimum operational requirements, and some kind of a guidance on at what points in their life that these can actually be collected also.
Uh, yeah, that is a very good point. Luckily, the data standards have become mature day by day, and the government of India, I know CDAC is actively working on it. They are working on the ABDM profile for data interoperability, which is a Fire-based profile that they've been creating, and of course they don't have to reinvent the wheel. There are other countries that are working on similar things as well, and they can learn from each other, help each other out, and come up with data standards. But that's the easy part. The harder part is implementing them at the front lines. Like you said, when you were seeing 200 patients a day, how are we going to collect the data? So, operationalizing those standards is going to be the hard part when a lot of medical records are still on paper. So, can we build a scalable medical record that integrates with the current workflow? So, if the application developer spends a few days shadowing a doctor in a clinic or a hospital, they would know what the everyday workflow is. So, how are we going to collect the data? Is there a way that the data can be collected outside a hospital or a clinic? Can the patient provide the data by themselves, especially if they don't know how to type or they don't speak English? So, can the app directly collect the data from a patient, and not only at uh, cross-sectional data, but also longitudinal data collection for several years? And how do we determine what data to collect from whom? I guess on the inpatient side, it's easier to collect data. On the outpatient side, as well as in the community, it's a lot harder to collect high quality, reliable data. So we have to start with small prototypes. I think that's the only way, because what has worked in one country will likely not work in another country, given the demand versus supply of healthcare resources, as well as all the language complexities. So we have to try it out with small proofs of concept and see how these can be scaled up. But at the same time, we need regulation as well as security infrastructure around data privacy, data security, de-identification requirements, and whatnot. So there are a lot of things that need to be done. But luckily, India can leapfrog a lot of other countries who have spent so much effort by trial and error and have overcome it. India can take the current state of the art from all over the world and see what will work for the Indian ecosystem. And once the de identification, security, privacy, the regulatory environment are all taken care of, as well as the applications that can work in high throughput environment can be developed, that is when we can get to the large scale data collection. And then we can determine what data should be collected from what patients, because we cannot go out and do whole DNA sequencing for everybody. So we have to, figure out what data to collect from whom and who gets access to those data, how, and what type of computational resources will they have access to for any kind of new medical knowledge discovery. So it is a complex problem. It's extremely complex. It's going to take a lot of investment as well as the right regulatory climate. But at the same time, a lot of the science is out there. So we don't have to reinvent the science. So that's one good thing about being able to leapfrog a lot of others who had to take the long road to get there.
Well, I think you kind of mentioned a lot of great points. Number one is that the relatively easy part is the technical standards. I'm only saying relatively easy. Again,
Yeah.
a lot of challenges in even kind of coming out with those standards. But the bigger challenge, I would rather even put the number 10x in front of it, is the operational challenge, because these are not just dependent on the technicalities but also the bandwidth, internet connectivity, the ecosystem that we actually don't have any access to or perhaps like control of. And if you add up one more 10x, which is the local context, as you rightly mentioned, the language is a challenge, and then the time that is kind of time that a patient actually engages with the doctor again varies. So these are all contextual challenges, which again adds up to another 10x. And even if we add up another 10x to this, healthcare is actually seen as a hospital centric activity, and most of these electronic health records are primarily designed for documenting what broadly happens within a hospital. And if we kind of take things away from the hospital, maybe even gathering limited information before they visit the hospital, or like let's say a community exercise, community healthcare service. And if we even push it to the patient's homes or even the person's home, where more and more healthcare is service is actually happening, we would kind of add another 10x to it. So it's actually 10x multiplied by 10x multiplied by 10x, which I think is already reaching 1,000 times by now. So it's a huge challenge that needs to be addressed. But this is also a great opportunity for the newly started School of Digital Health at Mallareddy Vishwavidyapit, where I think these are areas that we need to, as you rightly said, start experimenting on in a very small way, come out with small prototypes, see what works, and iteratively, hopefully, reach a point where something actually works at least up to clinical relevance or clinical standards. Because merely working versus working well in an ecosystem and then pushing it up for clinical relevancy again are huge steps that need to be taken. Given all these things that need to be done, in your opinion, what are all the things that we need to start teaching our students? Where do we actually start?
So, these days, luckily, students are very tech savvy. When we were in medical school, most of us graduated without ever touching a computer. Uh, Today, everybody uses a mobile device with the internet on it. So, I think we can build some, I would say, simulated environments. So, can we take, say, a publicly available electronic medical record system, an open source one, for example, and then load synthetic data into it and simulate what a patient's medical record would look like if the hospital were completely digitized? And what would the lab data look like? What would the pharmacy data look like? What would the patient's allergies and medications look like? So let's say if the patient is allergic to penicillins and you're trying to prescribe ampicillin, will the medical record cache that and say, hey, you're prescribing a drug that the patient is potentially allergic to? So there are a lot of things that we can do. If you want to start quickly for teaching purposes, we can set up a simulated hospital with synthetic data. And the real hospital can catch up with real data, because by the time a hospital can implement an electronic medical record system, a first year medical student would have completed their residency and would have started practicing, or at least finished their medical school, right? So I think there is a lot we can do without waiting for the real world ecosystem to be available. Luckily, because today there are a lot of open source tools that are publicly available, and it also helps students to understand, okay, what is possible today, what can be possible tomorrow. So you could integrate the current AI technologies into the into the simulated electronic health record with synthetic data, and they can see what can they do reliably, where are they not reliable. So they will get a good understanding for how technology can help them and where are the gaps. Potentially, some of them may be interested in doing uh, things themselves to improve those. So I think there's a fast way to get them started, even in a place where there isn't an electronic medical record that's available.
I think that's a fantastic way to probably go forward, because in some ways I think we are also planning to do something very similar, which is setting up a digital twin center where we would actually want to simulate a 500 bedded hospital, not just at the infrastructure level, but also simulate the environment of maybe 1,000 or 2,000 patients walking into the OP, and then maybe a subset of them kind of getting admitted and then hopefully getting treated, and with some kind of records that are actually created in the process, and see how what are the operational requirements are required at a registration, at every step of consultation, or every step that the patient actually moves through the hospital itself. So I think fantastic for actually raising that, because that's something that hopefully we can collaborate and work along also maybe in the next couple of years. And as you rightly said, it's not that we have to actually wait for reality to present itself before we make a case study out of it and then start teaching. Thankfully, environment for simulation reasonably exists at a mature level today, and we can simulate all those things. And maybe this is what is called as digital first, where digitization goes forward and reality catches up later, rather than maybe the old way where we are trying to kind of emulate reality to a digital platform. I think it's a great way to kind of collaborate for the future also. We have gone through fairly a lot of very interesting discussion points today, and it's been fantastic talking to you, not just about your past but also your present work, and your suggestions on what we can do in the near future also. Uh, Probably to the last question, how do we think we can collaborate, and how do you think we can learn from each other's experiences? You are in Utah, and then we are in India here at Mallaredi Vishwavidyapit. As you said, although we provide the service in a similar way, the way it is actually delivered is very different. The way it's documented is very different. And I'm sure we can learn from each other to understand what is presently happening. But potentially, if we leapfrog at certain point in time, I think what happens here could also be relevant universally. So, how can we collaborate?
Yes, there are some unique things that have come out of India that are examples of what I call as parsimonious innovation. So, innovation does not require unlimited time or unlimited resources. Like we see, people often talk about how much ISRO spends on its Mars mission versus how much was spent on the Martian movie, right? So, I think there is so much that can be done. And also, you have a very unique environment where there are millions of patients who are treated based on medical knowledge that's derived from an entirely different population. So there is so much we can do to improve precision medicine, address the genomic variation, the environmental differences, as well as the healthcare ecosystem in India. It's very different from from other countries. So all of these are areas of interest for me because I want my research to have the greatest impact possible. And as we saw from COVID, healthcare doesn't have borders. So and that applies for a virus. It applies for the knowledge and the motivation of doctors to help patients. So many of the areas that you're involved in, like simulations, as well as machine learning, machine translation, implementing technology in high throughput environments. I'm interested in all these areas, and they have complementary requirements to what I work on, which is knowledge extraction from text data, and how do we do it at scale, and at the same time do it with minimum resources, because I don't have the unlimited resources that the various AI companies have. As a professor at a university, I end up working on a shoestring budget as well. So there's a lot that we can collaborate on, and also I enjoy teaching too. So if there are guest lectures that your students can benefit from, I'd be totally up for that as well. So research collaborations, research mentoring, teaching, those are all avenues where we can collaborate. And
Well,
of course, thank you for the opportunity to collaborate with you. I'm super excited for that.
all of that sounds great. So hopefully we'll continue our engagement virtually, and we hope to see you soon here at Mallaredi Vishwavidyapit whenever you are here, or maybe we'll work out some kind of a schedule for you to be invited here and kind of engage with our students and also with the research environment that our ecosystem that we are actually creating. Well, thanks a lot for your time, and it's been fantastic talking to you. Learned a lot, and hope our viewers and students will learn even more. Thank you very much.
Yeah, thank you, Dr. Suresh. It's a pleasure talking to you, and I hope to talk to you a lot more. See you then.